and I'm going to restart my presentation now. So for those who have logged in now, I think you can just start listening to the presentation from this point. So thank you, Creative International and Apollo Information Center, Kenya, for giving me this opportunity to present live on spine surgery. And myself, Dr. Pramod Sudarshan, Senior Consultant Spine Surgeon from Apollo Hospitals, Bangalore. And I'm going to talk about minimally invasive and advanced spine surgery using 3D printing and navigation, a glimpse into complex spine surgery. So before going into the talk, I'll just give my background. So I've done my master's in orthopedics and fellowship in spine surgery from Apollo Hospitals, Chennai, under the Association of Spine Surgeons of India. And I've been active in academics with multiple awards from, I've been the only Indian to get a consecutive awards from Texas, from the International Spine Association conferences in USA, from Japanese Scoliosis Society in 2018, and from SICOT conferences in Oman. I hold 5 international fellowships and trainings from mainly focused on scoliosis and deformity correction surgeries. I guess from Denmark in 2016 and Texas Children's Hospital, USA. And I've been a visiting surgeon for Focus Hospital in Africa, where we operated with Professor Boashi and did complex spine surgeries, scoliosis surgeries. And I'm also an author of textbook and numerous chapters in spine books with focus on robotic guided spine surgeries. And I've been an active academician and research person. So I got the highest award from for the best paper from the annual conference of Association of Spine Surgeons of India. That's the VTI Gold Medal in 2022 for a topic on scoliosis. And these are my publications from the last few years, which are all published in international journals. I hold memberships of ASSI, Asia Pacific Spine Society, and Indian Orthopedic Association, amongst others. And also hold social responsibility in managing school screening programs and honorary deformity correction surgeries in children. So I've been an editorial board member of Indian Spine Journal and a task force member of QSMA Foundation of India. So before we go into the latest advances in spine surgery and the latest technical variations which we follow in India, I would like to just explain the spectrum of spinal disorders, because spine is vast and we can divide it into degenerative problems to deformities to bone health issues and neurological issues. So the common spine conditions what we see are degenerative conditions which are age-related in disc prolapse, spondylolisthesis, etc. The infective conditions like tuberculosis, pyogenic, and fungal. These are common. I understand that they are common in Africa as well, as common as it is in India, because of the number of references we get for these conditions. We see primary bone tumors like spine tumors like myelomas. We see metastasis from different regions of the body to the spine. And we also see a lot of deformities and spine trauma and metabolic and miscellaneous conditions. So if you see degenerative spine conditions, disc prolapse is the most common, followed by spondylolisthesis and cervical radiculopathies and myelopathies. So if you see disc surgeries, we used to do everything open probably a decade back. So we used to do open and microscopic surgeries. But my practice over the last 4-5 years has completely shifted to endoscopic spine surgery, where I use the unilateral biportal endoscopy technique, which is the UB technique. And this UB technique makes sure that you just go to 2 keyholes. If you see, these are 2 keyholes which I use to enter the spine. So one I use for the camera, one used for the working portal. And once we go inside, we have everything which we can do in open surgery, like burying the bone, like removal of the bone, removal of the flavum, and removal of the disc. Everything can be done using endoscopy. So this is an example of a 30-year-old gentleman who had a disc problem where we had to remove the disc, and we just removed it with endoscopic technique, and the patients walked on the same day. So this is another example of an elderly lady who had a 2-level problem, and multiple level problems also can be tackled easily with this endoscopic technique. You can see after the surgery, the nerves are completely free, the disc is completely removed, and both sides we can visualize the free nerves. For example, just yesterday morning, I operated on a patient from Iraq, and the patient got operated yesterday morning, got discharged yesterday night, and next week he's ready to go back. And for international patients, this technique is definitely a boon for early recovery and fast, quick outcomes. So this example of, again, elderly patient with laminectomy decompression, we can do it with endoscopy. Previously, we used to do everything open. Again, this technique helps us to do everything under endoscopy. So this example of degenerative spondylolisthesis, this is what we do day in and day out. Every day almost we do these surgeries where we call it as spinal fusion surgeries. So these surgeries are done by removing the entire disc and replacing with a metal implant, and we put screws above and below to make sure that the spine fuses. So this surgery is very common, and we do it in all age groups, and we can do it in different varieties like using metal cages, PEEK cages, hybrid bone graft surgeries, etc. And these kind of high-grade listhesis, which are complex surgeries, can also be done using the same technique where we reduce the spine back into position. You see that the spine, which was completely toppled over, you can call, and it got reduced and fixed into that position quite comfortably after the surgery. So similarly, in the neck, we can see the disc prolapse happening in the neck, where we have the disc compressing on the spinal cord or the nerve. We can remove the disc and replace it with an implant, which is a minimally invasive implant called as a standalone cage with screws. So previously, we used to use a lot of plate and screws on this, and plates used to cause difficulty in swallowing. So that changed over the last decade or so. We have completely moved on to this standalone cages, which are very effective. And when the disc compression is more than 2 levels and it is compressing on the spinal cord, we call it a cervical myelopathy. Patients usually have difficulty in walking, difficulty imbalance while walking or holding objects. So these surgeries, like I call it as a jewel in your neck. So you can remove the entire bone in the vertebral body and put a cage and put screws and plates over that. And when we do it from posteriorly, we call it as posterior laminectomy and fusion, where multiple levels of the spine can be decompressed, and you can see that the spinal cord is completely free from compression after the surgery. So spine trauma is quite common in India, and I understand that it's also common in Africa because road traffic accidents are high, fall from height injuries are high. So these examples of cases where we have done trauma surgeries, where we do the surgeries and the patient can walk the next day and go home the second day after surgery. So it's as simple and as effective as that. But in some cases where the patients usually have neurological deficits, because if you see the spine here, the spine is complete, the fracture is completely compressing on the nerve, and it is compressing on the nerve and causing paraparesis. So the patient was paralyzed below the level of the hips after the surgery. And this is at 3 months after the surgery, where the patient is completely walking pain-free and neurological deficits has completely recovered. So sometimes we do the surgeries just to stabilize the spine so that the rehabilitation can happen comfortably. Even though patient is paralyzed, we do the surgeries so that the rehabilitation part is taken care of. But in elderly patients where the bones are weak, they can have osteoporotic fractures without having major falls or major injuries. So in those cases, we use the bone cement. These are all bone cement impacted examples where we have put bone cement and we have stabilized the spine. For example, this patient underwent bone cement fixation in this fracture, and the patient started walking 4 hours after surgery. Or somebody who was bedridden for a month started walking 4 hours after surgery. So this example of cement augmented screws can be seen in osteoporotic fracture, which has led to non-union, where the patient has the fracture is not united, and then the fracture helps to, the fixation helps to heal, and we can use the cemented screws for fixation in these cases. Again, an example of non-union where the fracture has not healed, and we put cement above the level of the fixation just to prevent future fractures, and then at the level of fracture so that the healing happens well. So tuberculosis and infections are quite common, and these are different examples of tuberculosis where we have done the surgeries, have done long fixations. Example of infections in the neck where the patient had a tuberculosis infection, and the patient actually literally walked into my OPD with just neck pain, and just because of our clinical suspicion, we got an MRI done, and we could see that the infection was quite bad. She could have ended up with paralysis quite easily if we had not operated. We had to do a surgery immediately, and different kind of examples of infections like that. So tumors also are quite common. So we have been working in an oncology institute for the last decade. So I've been getting a lot of referrals from oncologists for fixations, prophylactic fixations, and definitive surgeries like myelomas, where we do the instrumentations and cementing, or different kinds of tumors like thyroid cancers spreading to the spine, thyroid metastasis to the spine, or melanomas from the skin, or even like Ewing sarcoma of the tumor of the bone. All of these can be operated, and dural tumors, like the tumor is there inside the spinal cord like this, where we can remove the tumor safely and decompress the spine. Once revision spine surgeries are also quite common in centers where they've already undergone surgery and the surgeries have failed or the implants have failed, and they come for second or third surgeries. For example, this patient came from Bangladesh. The patient had undergone surgery twice, and the patient did not this patient was from Africa, where we had to do an adjacent segment fixation. This patient had surgery twice, and the patient had multiple problems in implant failure, a leak of the cement, infections, and junctional failure. So where we did long fixations and we have corrected the problem. And this patient had operated in Bangladesh, 3 times operated, and then this patient had multiple surgeries, and we had to revise the surgery, revise the implants and fix the spine. So sometimes the primary surgery fails, and then the screws have to revise and fix the spine. In the spine. This can be detected as early as at birth, and this surgery can be done as early as 4 years of age. So this girl underwent a small surgery at the age of 6 years, and the patient could do well after the surgery. Again, post-tuberculosis, the spine can bend and cause deformity. So this patient underwent this surgery and had a kyphosis correction, a Scheuermann kyphosis correction in an 80-year-old boy, an osteoporotic kyphosis correction in an elderly male, because the fracture had not healed and his patient started bending forwards. And if you see this, the patient started correcting from the bent position, which is called as kyphosis, to the straight position after surgery. So scoliosis, again, is a very difficult condition to manage, very complex condition. This usually happens in adolescence at the puberty because of the growth spurt. When the children start to grow and they attain menarche, especially the girls, their spines tend to shift to the sides. And this condition is quite common in African countries, where I've seen a lot of complex deformities, a lot of neglected deformities going very bad, and then we have to do surgery at a later stages. So when the patients come at earlier stages, you can see the difference the outcome can make, where the spine can be corrected from this position. This severe deformity can be corrected to an extremely straight spine, and the good balance can be obtained after surgeries. These are all examples of different children who have undergone surgery under my care, and they have been doing extremely well. We have got very good corrections in young girls who have now become, they've reached a stage where they themselves are studying medicine. They themselves are doing all the work. We get international patients from different countries, and we do these surgeries. And these are my few of my examples of surgeries which are done just last week or last month. And we also do surgeries on the spinal muscular atrophy, which is a complex condition. So this condition does not allow the child to walk, because most of the children are wheelchair bound. And because of the load of the spine keeps tilting like this. So the spine tilts to a side, and then we have to do a long fixation and then correct the deformity. And these are all the examples of my children who have undergone those corrections. Degenerative scoliosis in elderly can be corrected, and the patients can do well after surgery. So coming to the modern spine care or the recent advances. So we do have different kinds of advances which are available. Robotics is one, navigation is one, minimally invasive spine surgery or endoscopy, which I've already shown to you, is one. 3D printing and augmented reality are different advances which we see nowadays. So robotic spine surgery, I was one of the earliest to be trained in robotic spine surgery in India. We had, as early as 2014, when we were training, we had the robotic spine exposure with us. And then again, navigation, we do have OARM and navigation in our hospital here in Apollo Hospital in Bangalore. So this OARM is like a GPS or a navigation for the spine. So when we use to go somewhere, we use Google Maps. Similarly, when we are doing the surgery, the patient can undergo this OARM screening, where we know exactly where we are going to place the screws. And for complex surgeries like this, we can actually use OARM, and then this helps us to guide the screw, and complex screws can be done. If you see, we are actually looking at this screen, and we are actually guiding the implants or the screws using those implants, and looking at the screen there, the guidance can be done, and safely the patient can undergo the surgery, and the outcomes of the surgery will be very good, where the fixations of the screws are accurate and the patient can do well after surgery. 3D printing is another advancement where we look at the low cost and high benefit. For example, this patient who had a tuberculosis of the spine had to undergo a spinopelvic fixation, and we did a personalized 3D printed model of this, and then this was the 3D printed guide which was used on the patient's spine to accurately put the screw. And once the surgery was done, we did a CT scan to just see how good the screw position was, and it was excellently guided. So again, advanced surgeries like augmented reality fixations are coming up. I was one of the earliest to again visit Indonesia to learn the augmented reality training in one of the hospitals, and then you can see that once the surgery was done, we could accurately put the screws in. All this was done under the head mounted display where we are wearing on the head. We don't have to look at any of the screens while doing these surgeries. So just takeaway of this talk today from our end is that spine surgery is safe and effective and has evolved over the last couple of decades. The 3T's, technique, training, and technology has revolutionized spine practice, and outcomes are good if it's performed by an experienced surgeon at a center with all advanced facilities. Thanks a lot for the patient hearing, and we would go in for discussion of the questions we have, and I would like to encourage all the discussions and questions from your end. Thank you. So I'm just seeing some of the questions from the chat box. So I'll be just going to the chat box and reading out those questions and trying to answer those questions from the chat box. So yeah, scoliosis correction surgery, like we discussed, the surgery is done usually at around 10 to 12 years of age. So the patient usually comes for surgery at around 11 or 12 years of age at the time of menarche, and the correction can be done safely. It's a complex surgery. Nowadays, we are doing all these corrections under OARM and navigation, and the correction can happen quite well, and the patient can lead a normal life with the surgery. And usually it can be done for congenital scoliosis, like for the young patients who are like born with scoliosis, we can do as early as 4 or 5 years of age. For children of 10 to 11 years for idiopathic scoliosis, we do the surgeries at that age group. And then the neuronavigation, so when we use the navigation, what happens is the patient, when we have the spine exposed, we actually use the O-arm spin. We call it as a spin. So it's like an intraoperative CT scan. So when the CT scan is taken of the patient, then the navigation helps us to accurately guide the position. So if this is the spine and the navigation is helping us to guide the screw exactly there, and we are looking at the monitor and the CT scan of the patient so that we know where the spinal canal is, where the nerves are, and we can safely avoid those trajectories and place the screws in the right position. So the risks of minimally invasive surgery, yes, the spine surgery is inherently has risk of neurological problems, but again, minimally invasive spine surgery, which is done under endoscopy or navigation, is extremely safe, and we usually give almost risk and success rate of the surgery as 98 to 99% successful surgery, with only 1 to 2% of risk of neurological problems happening with surgery. Because everything is visualized well. The endoscopy helps us to visualize the spine well. The navigation helps us to visualize the screws well. And when we use all these advanced technologies, the risks have almost come down to minimum of 1 to 2% compared to what we used to see like 10 to 15% earlier, maybe a decade ago. What could be causing back pain? Back pain generally has a lot of causes. So if you have the 90% of the cases, back pain is mostly mechanical because of poor posture, because of continuous sitting, desk jobs nowadays, continuous traveling, lack of exercises, lack of core muscle strength, improper lifting techniques. Those are very common to cause back pain. As I said, 90% of the time back pain is caused by these things, and which does not require surgery. In 10% of the times, back pain can be caused by all those conditions which I showed, like disc prolapse, like degenerations, infections, tumors, trauma. These things can cause the back pain in the rest of the 10-15%. And benefits of 3D printing. Again, 3D printing is a low-cost, high-benefit surgery. So if a center cannot afford navigation, all centers cannot afford having big machines like navigations or robots. So 3D printing helps us to customize the guides for each patient. So in terms of dollars, probably if I'm talking, 3D printing helps us to customize for an individual patient in roughly around $300 or so, which cannot be matched with navigation. The navigation is much more expensive. So 3D printing helps us to do give good outcomes with low cost in complex surgeries. Is congenital scoliosis treatable? Yes. So congenital scoliosis has to be treated at an earlier age. If we see an extra bone called as hemivertebra, if there are extra bones in the spine, we have to actually go in and remove the hemivertebra so that the spine doesn't curve too much before it becomes worse and before it becomes. So what we see in Africa, like Ethiopia, Tanzania, Kenya, most common is that the congenital scoliosis is not treated at the young age. The patients are left to grow, and the scoliosis is left to grow till the age of 15, 11, 12, 13. And at that time, the spine is already curved for more than 80 or 100 degrees, and then the surgery becomes very complex. So moderate disc bulge. So in case of moderate disc bulges, the treatment is mostly, again, conservative in form of bed rest and medicines and physiotherapy. The most of the times we manage disc prolapse with disc bulges with bed rest and medicines. And once the pain gets better, physiotherapy will help. And at the most, we may probably advise an injection in the spine, in the spinal canal, where we give an injection there, and then the nerve becomes free of compression. So only severe patients, like 1 in 10 patients whom the patient is not getting the. So I have a herniated disc. Can you help me? Of course. I think if somebody has a herniated disc, and if anybody has a spine problem like herniated disc or spondylolisthesis or any kind of spine problems, what you can do is you can share your details, your clinical details, like what problem do you have. You can share your MRI or images and reports you can WhatsApp directly at the number which is mentioned below in the chat box, and you can actually WhatsApp directly the reports, so that the reports are they can reach me out with the reports. I can see the reports and the images, and I can look at your clinical condition and decide on what needs to be done. If the condition is simple, which can be managed with medicines and exercises, I would suggest the same. But if the condition is complex and which requires some surgery like endoscopy, keyhole surgery, or advanced surgeries, I would recommend you to visit me, and we can take it forward from there. But as a first step, we can always get the reports and see the reports and advise you what is the best which can do. I hope I have answered all the questions in the chat box. Any questions left or any new questions, please, I think I can answer further. Yeah, I get another question. How do you treat chronic back pain associated with weakness on the lower body, numbness, and tingling? So, chronic low back pain associated with weakness of the lower body and numbness and tingling can be mainly because of compression on the nerve called as spinal canal stenosis. So, in case of spinal canal stenosis, we need to see if there is any instability of the spine, or is it only the nerve compression which is causing that. And if the compression is associated with instability, we would advise a minimally invasive fusion surgery for that. And if with the decompression, so when we go in, we just put the implants and we make sure that the spinal canal or the nerves which are compressed are freed from the compression. So this relieves the numbness and the tingling sensation, and also it improves the weakness of the lower body because of the compression on the nerve, and gradually the patient will be able to walk and will be able to get back to a normal life after the surgery. Yes, I think I don't see any other questions in the chat box, and I think we can end the live video session here. Thanks to everyone who have joined the session, and thanks for the comments and the questions which were there in the chat box. It was very encouraging to see. As I said, you're welcome to message or WhatsApp your queries send the reports on the chat box, the number given in the chat box, and we would be happy to receive the reports, see the reports, and review the reports, and then we can probably even have a video discussion on a case-to-case basis, individual basis, before we decide on whether you have to come to India for treatment, or we can manage the condition there. So we can do that, and then we'll look forward to getting the queries and managing the spine problems. We are here to help you, and we are here to make your spine straight and get back to action. And that's it for today. Thank you. Thanks a lot for joining, and take care. Great evening to all.